And thank you all for joining us tonight. It's a fly through for an hour, and hopefully we can work together to find some teaching points and serve our patients as the best we can. So I do I echo Laura's acknowledgement of the traditional custodians of the many lands which we are gathered on this evening. I join you from Turrbal Country and the land of the Kabi people. We pay respect to elders past, present and emerging, and we honour the rich history of the Aboriginal and Torres Strait Islander people by gathering this evening to share our knowledge and care for our communities. As when you signed up, you would have seen our learning objectives for this evening. So the three main learning objectives tonight are to identify the most appropriate diagnostic imaging pathways for symptomatic patients, a bit of a guide to the interpretation of the BI-RADS assessment categories, and then identify breast imaging techniques in moderate to high risk individuals. So let's start with diagnostic breast imaging. So this is the investigation of symptomatic patients. As you would know, we sort of have to put on two hats when we think about how we image our women, and that is diagnostic breast imaging and screening. And sometimes there feels like there's crossover, particularly in those high-risk women. So let's work together and get through how we untangle those two situations. So I've lent on this article from Cancer Australia, which I'm not sure how many of you have reviewed in the past, but this was a nice general guide for the general practitioners. And I've referred to this to see where my opinion and the practical implications of this guideline come into play from a diagnostic imaging point of view. So I'd recommend that you take time and have a look through this PDF if you've ever got any questions. So we start with the triple test. Now, as we know, the triple test is history and clinical examination, imaging and biopsy. And we also all know that these three things only rarely go in this order, and we often loop back. And in my experience, we essentially have, I won't say two tiers, but two sections. So there's sort of like the first line imaging, the first line examination, and then we move up and down and across to the higher end techniques. So in our circumstances, the first presentation is a clinical symptom to the general practitioner. The front line or first line of investigation on our side is always ultrasound and mammography. And then the easiest biopsies to perform are aspiration, core biopsy, and in some centres, vacuum assisted breast biopsy. Now, when any of those three things do not add up, then we can step to the next line, which is examination by a breast surgeon and referral for consideration of additional investigation. From an imaging point of view, the next step is often MRI. And from improving our tissue sampling, again, we have VAB or a larger size VAB sometimes, or an excisional biopsy by the surgeon themselves. This is a complex second page to this guideline from Cancer Australia. So I am going to break it down into small areas. We can't go through every component, but I have taken away what I think is important for us this evening to work through. So the first point that is relevant, that I see most relevant in my clinics, is the urgency of referral and the communication between the referrers and the radiologists or our technicians, and actually most importantly our bookings team, of how to triage requests. We are all under-resourced, and so we are always trying to find and pick out these urgent requests. So in my opinion, and in my clinics, my administrative and booking staff are trained to either find the word urgent or find any of these indications. So a new palpable lump in a woman who doesn't have cysts, but even still, as we all know, there's a challenge there with those women who have lots of cysts. They come with a new palpable lump all the time, and we have to work through that each time because we don't want to assume something is benign just because they've had lumps in the past. Nipple changes are very important, so a rash or retraction. Skin changes, dimpling. If you tell me there's dimpling, we will pay a lot of attention to that area. Change in breast size. So obviously, if you've got a mass that's growing is one thing, but the higher grade tumours and the inflammatory breast cancers can actually result in a firmer and smaller breast. So the shrinking breast is also a big red flag. And obviously, a bloody nipple discharge is an important presentation and not to be ignored. Your referral wording also matters, and 35 is the age where we divide our processes, and obviously arbitrary line. So in a woman under 35, the standard practice in most clinics will be to book an ultrasound first, and this can be reflected in your referrals. So ultrasound plus or minus mammography, plus or minus biopsy. The reason for that is there are many causes for benign presentations in these women. The breast cancers that young women do tend to get are often quite obvious on ultrasound. So we do have good sensitivity in that with that modality, and the mammography is important once we find a suspicious finding. In these circumstances of extent of disease, in the case of DCIS, to look for that calcification. So ultrasound alone can sometimes resolve if it's a categorically benign finding. But mammography is very important to then determine disease and level of suspicion. So it's important to have both components on your request form in that area. The exception to this would be a completely malignant feeling mass. And if you presented a referral to me in a young woman, but everything sounded very much like breast cancer, I would probably do the mammography first because I think it's going to happen regardless. But that's sort of at the discretion of the radiologist in the clinic. Now, the second option is women over 35. So investigation of a new breast symptom in a woman over 35 is mammography and ultrasound. And really, we can't get to a final category when we go through BI-RADS category without those two tests, and plus or minus biopsy. I can't speak to how each clinic that we all come from or your referral centres are going to operate. There are clinics where it's a comprehensive all-day breast clinic where biopsies are accommodated on the day if possible. I know some general practitioners would like to see the result of the diagnostic test first before they refer to biopsy and have that, that ability to interact with their patient between those two steps. And then some clinics will actually prefer to decouple that diagnostic imaging and the procedural appointments, and that just allows for better planning, the right modality for the sampling, good samples, a prepared patient. It's obviously an emotional time, particularly when we're highly suspicious. So it's important to us to convey your level of clinical suspicion. It will determine how firmly we recommend the next test. If there's a patient who on clinical examination for everything that's important, it just feels like breast cancer and you're not going to rest, then if that's conveyed in the way the referral is written, and I can't find an abnormality, I'll be very much advocating to do an MRI. And that's often important when we think about Medicare billing, or not billing so much as Medicare indications. There is an indication for a clinically suspicious lesion with no mammographic or ultrasound lesion identified. So if we're in that clinical suspicion area, then the words of my report sort of will enable the breast surgeon to then make the referral for an MRI that Medicare will cover. So mammography is a very generic term now. It's done a full circle of being the only term we used. And then I think, and now I use it to cover all the different types of mammography we're performing. So traditional 2D mammography, this started as film screen, it's digital now. This is what is performed with breast screen as a screening mammogram and forms a component in other examinations. The next step was 2D tomosynthesis, or 3D mammography, is also a term used. Now, it's not quite the same as computed tomography in that like in a CT, we have a 3D data set that we can restructure and reformat into different views. This is slightly different. We're obligated to the view, but the levels above and below the slice are blurred out. So we can get these nice images where we can see crisp edges. In this case, this is a lady with multiple cysts, and just reassure ourselves that this is a benign finding. The new kid on the block is contrast enhanced mammography, and I do have a few slides on that coming up, so I won't delve too deeply in there, but a beautiful test. And this is a recent case of mine with multiple lesions. So she actually presented with that enhancing area near to her nipple. That was her palpable area. We can see that she has this additional spiculated lesion sitting posteriorly, which is obviously larger, and also a few enhancing foci, which are likely her satellites, which we never would have been able to detect here on her standard mammography. It also will include workup mammography. So in a breast clinic, when a patient has their first mammogram or tomosynthesis, a cone compression view is at this view. We do cone compression tomosynthesis now, where we may see all of these densities and they don't look quite right, but they don't quite look like cancer. And a cone compression is further compression in a small area which disperses the tissue, and it softens normal appearing tissue, like normal fibroglandular parenchyma. And in the case of a cancer, it will show those spiculations and the distortion a little bit better for us. And I am very aware that you can probably not see any of the calcification in this image, but I promise you they are here in a magnification view. So magnification views is purely for the characterization of calcification. It gives us a better spatial resolution, so we can see more of those calcifications and the morphology and distribution of them to determine whether they're benign, indeterminate, or suspicious. So here we go for some contrast enhanced mammography. So while it's new in our clinics, and we're still working our way through how to deploy SEM into the most clinics that we can, it's actually been around for over 10 years in a research and tertiary environment overseas. So as with CT, we're using tumour angiogenesis to distinguish between normal tissue, which enhances a small amount, from malignancy, which enhances more. So essentially, we're using the same tomosynthesis machines that we have in our clinics. They're just having an upgrade. We use standard mammographic positions for the basic acquisitions. We use iodinated contrast and an IV pressure injector, so exactly the same as CT from a procedural point of view. And we know that it's improving malignancy detection in all patient groups with a greater effect in increased breast density, which we'll look at some images in a moment. The improved malignancy detection, studies keep coming out all the time, and it really is performing almost as well as MRI. There's a reason not to do it in everybody, and MRI still remains the gold standard, and we'll talk about that in the high-risk groups in a moment. So for clinically, we obviously have to consider the same things that we would consider for CT, and that is renal impairment, any allergies to contrast in the past, or high-risk allergies, and metformin use with renal impairment. We are not imaging within the menstrual cycle, so we are offering SEM at all times in the menstrual cycle. We do know that there is periods of time where the tissue is more active and less active when it comes to background parenchymal enhancement, but we are just working through that. So one of the benefits is not having to time with cycle as we have in the past with MRI. So from an imaging point of view, we take two images, a low KV and a high KV image. They look fairly similar when you look at this image. We are, as radiologists and on our packs presenting to you, we only present to you the low KV image, and it is, to our eye, indistinguishable from a standard 2D mammogram. The high KV uses some components of the acquisition to create a subtraction image. And as you can see, we have this nice bright enhancing lesion superiorly in that breast, and all the other areas of white are actually the background parenchymal enhancement. So that's active breast tissue. And obviously, the more of that we have in an image, the less accurate the study is. But you can see that there is a difference between the degree of enhancement of the background and the degree of the enhancement of that lesion. So as a little, for interest's sake, the technical component we'll quickly touch here. So the woman has her IV sited, she has her injection of contrast, and we wait 2 minutes for the contrast to get into the breast tissue. The mammographer then has about 6 minutes to acquire the images required. And they get, every time we roll out to a new clinic, the mammographers are concerned about how long that they're going to take their images. And once they're settled in and thinking about it, we have plenty of time. And often we do have time at the end to do some additional images if there is an abnormal finding. So our mammographers are getting increasingly experienced and achieve this in a very short amount of time. Here is another study, just because pictures are nice and you're at a radiology discussion. As you can see in the first 2D image, there's that spiculated area posteriorly, and I would hope that all the radiologists would find that, and probably everyone in the room could see that as an abnormal area on a mammogram. When the 3D was done, the tomosynthesis, there's an area of distortion in that second view. That's a magnified area. But as you can see on the contrast in the last image, that lesion is quite big, and we wouldn't have predicted that. And it's another study you can see just behind that, the larger of those two lesions, that we can see a little area that's probably a satellite of enhancement as well. So contrast mammography serves two excellent purposes, and that is in the detection of breast cancer in dense breasts where the lesions can be obscured, but also in extent of disease to really ascertain whether there's satellite lesions or multifocal malignancy. Another study, that little triangle is a skin marker that we put on when a woman has a palpable region of interest. So you've got an idea of where we're going through, but honestly, there's not a lot going on in those 2D images. But look how big that cancer is, and we can see the extent of that enhancement. Again, it's a nice way to confirm your suspicions if there's a tomosynthesis abnormality. To be complete, I'm adding in some benefits and limitations of ultrasound, as I think sometimes these aren't entirely understood when it comes to why do we do 2 tests when we should just do 1. So obviously ultrasound has no radiation. It's more comfortable for the patients than to have their breasts in compression. Gives us an ability to distinguish between cysts and solid lesions. So a rounded solid lesion or a rounded lesion on mammography could be a cyst, it could be a fibroadenoma, it could be a mucinous tumor, could be a papilloma, and ultrasound gives us the ability to distinguish these things. We can assess for internal vascularity. So in the absence of contrast, where we are obviously assessing for vascularity, the ultrasound gives us a level of suspicion based on the vascularity within a lesion. It is our preferred modality for biopsy planning. So when we find a lesion under any other modality, we are searching very hard for any sonographic abnormality. Women much prefer an ultrasound-guided biopsy. Our limitations are it's very operator dependent. So we have wonderful breast sonographers, and that's all they do, or general sonographers who do whole days of breasts and are highly trained. And then there's other sonographers who have not had that level of experience and maybe overcall or have more trouble distinguishing between benign and malignant findings, because there is a crossover. So there are many benign lesions that appear very nasty on ultrasound, and we have to do the biopsy and find out what they are. And similarly, every now and then you get caught out by something you think is quite benign on ultrasound and it turns out to be a malignancy. It can be really lengthy in complex breasts. So those women who have multiple cysts, multiple fibroadenomas, just generally what I would call messy breasts, but just really complicated parenchyma, they can take up to an hour to scan, and that is actually exhausting from a sonographer's point of view. The amount of focus they have when they perform the study is quite in depth, and we cannot see calcification. And that is the main reason that ultrasound can't be used as a screening test. That calcification as a sign of DCIS before we have invasive malignancy is what we're here to achieve. So by the time you can see an ultrasound abnormality in the case of DCIS, you're probably actually seeing the invasive disease. So next step on our journey is BI-RADS. Now, my aims here are to give guidance about when to stop imaging, when to observe, and when to biopsy. As you would be aware, we have all the RADS. So all the RADS are from the American College of Radiology guidelines, and the RAD is a reporting and data system. So there's BI-RADS, there's TI-RADS, there's LI-RADS, there's PI-RADS. We all have a RADS. We've got ORADS now as well. So it provides a standardized breast imaging terminology. It should determine how our reports are organised. We have an assessment structure, a classification system. It covers all modalities. There is an additional area now as well, like in mammography, that includes contrast mammography. It enables us to communicate with you clearly and consistently with a final assessment and specific management recommendations. So from my side, this is what it looks like, which is very complicated, and I am not going through this with you today, but it tells us the language that we should be using. And when we speak in this language amongst ourselves, we know if I say fine linear branching calcification, I'm telling you that this calcification in the breast is malignant and I'm concerned. However, if I say something is popcorn-like calcification, I'm telling you that's a fibroadenoma and it's benign and categorically benign at that. So this is how we communicate amongst ourselves, and you'll see these words echoed in our reports. But what's important for us tonight is this. So when we get to a category of assessment, what do we do next? What does that mean? When can we sit and when do we need to act? So we're going to put these two components side by side. We've got assessment categories of mammography or ultrasound as our first line test, as we said. What happens now once we've found these lesions? So we have here as normal breast tissue, benign, indeterminate, suspicious or malignant, which essentially aligns with our BI-RADS categories plus a couple of extras. So let's go through. So BI-RADS 0 is an incomplete assessment. So we can use that when the patient is unable to complete the imaging. This might be unable to tolerate compression in the mammogram, unable to position, some sort of habitus issue where they're quite kyphotic and we can't get all the breast tissue. So we can say, look, from what we can see, we can see that there's no malignancy. However, we just could not cover the whole breast. When we know previous images exist but are not available for comparison at the time of reporting. Now, this is something that varies between radiologists. Some of us will report on the day and come back and do an addendum when we have additional imaging. So this is when that will get used. The reporter will put out the report that will say, we're retrieving the priors from another provider, but they're not available right now. So I'm going to call it BI-RADS 0, but I'm going to do an addendum when they're available to me. Alternatively, some radiologists will hold the report and not release the report until the priors are available for comparison if we know they're coming. So the third option is if a referral is sent for one only mammography or only ultrasound to investigate something that is considered clinically suspicious. And in those circumstances, we can't make a judgment, and that report will come with a recommendation. So as I've said in what to do next, if you get a 0, you really should have a next step identified for you as to what you should do and what the limitation is, if we can overcome it or not. We don't use it to encourage characterization with MRI. This BI-RADS category should be assigned either at the end of one or another study, or a combined mammographic and ultrasound examination. We then reach a BI-RADS category, and sometimes that requires an MRI for characterization or for level of concern. So we shouldn't use a 0 to have an MRI, and we shouldn't use a 0 while we wait for a biopsy. So we do need to, it should be the BI-RADS category that drives the biopsy, not the other way around. BI-RADS 1 is negative, no significant finding or findings within the scope of normal. So dense tissue is just on the scale of normal. It has an impact on how sensitive and specific we are as readers, but it's not a pathology, it's normal tissue. So essentially anything the reporter chooses to ignore as normal. We don't use it for benign lesions. And if you get a BI-RADS 1 study and you think it's concordant with examination, the most common one for this is the ridge of dense parenchyma. And we've completed the imaging, we've completed the ultrasound. The woman is able to say, this is my finding. And we put the ultrasound probe on, and it's clearly a very superficial ridge of tissue. In those cases, then we just determine the next screening interval and recommend screening. If discordant with examination, then we consider surgical referral and MRI in whichever order that's available for you. Benign lesions, again, we're saying absolutely not malignant and you can leave them alone. So it's when we decide to describe a lesion. So there is crossover with what some radiologists will call a BI-RADS 1 and BI-RADS 2. So calcified fibroadenomas, skin calcification, foreign bodies, fat-containing lesions, benign intramammary lymph nodes, vascular calcifications, breast prostheses, typical surgical change, including distortions and seromas, simple cysts that satisfy our benign criteria for a cyst, stable complicated cysts and probable fibroadenomata, which we will talk about in a moment, and biopsy-proven benign lesions. We don't use it for anything that has an atypical feature, and we have essentially the same recommendation for what to do next. If it's concordant, we go back to screening. If it's discordant, we do something else. BI-RADS 3 is where we all run into trouble, I think, and how radiologists use it and how we interpret it on the other side. And I think it is hard for a GP. So the recommendation for a BI-RADS 3 lesion when we get there is biopsy or follow-up. And it's very hard, I think, as a referrer, as a GP, to get a report back that says BI-RADS 3, probably benign, but don't do anything about it. So I'm here to reassure you that it's a less than 2% likelihood of malignancy. It is a very narrow category to assign to a lesion, but a lot of lesions fall into this category. So it's really only for these well-defined masses on mammography, a focal asymmetry with benign features, categorically benign looking parenchyma, or a solitary group of punctate calcifications. So no suspicious features, but it's just the only calcification you can see in the breast, and we don't have anything else to marry it up with. On ultrasound, the likely fibroadenoma, which is a circumscribed lesion in oval shape and parallel orientation, and it's hypoechoic and it's homogeneous. They're the rules that the lesion has to follow. A complicated cyst can look very similar to a fibroadenoma, and that's why it is included in this category, and clustered microcysts, so fibrocystic change. Now, not used for new palpable lesions and not used for new lesions or lesions increasing in size. And this is where I think it's very tricky. So the ruling is that you should really only use a BI-RADS 3 on the first imaging, and everything after that, because you've got a comparison study, you really should be able to assign it as either slow growing or stable in size, or reducing in size, therefore benign, or it's new and we're suspicious about it. Now, I'm going to put the cat amongst the pigeons here, and that is the women who have multiple cysts and multiple fibroadenomata, and particularly young women who are like that. I don't want to be going through and biopsying every new fibroadenoma in a 27-year-old woman who is known to have 12 fibroadenoma already. So I think we need to be cautious and sensible in those narrow circumstances, but it's certainly one of the things I'm most passionate about, that we don't over biopsy young women and turn them off their breast imaging for the rest of their life. So the recommendation is, if you have a lesion that is called BI-RADS 3, you do a 6-month follow-up of the finding only. So if it's one of those punctate clusters of punctate calcification, that's in 6 months. 6 months mammogram, and should be with the same views. But if we're talking about these query fibroadenoma or query complicated cysts, then we look at the 6-month ultrasound. We assign, if it's stable, we assign a category 3 again, and we repeat the 6-month follow-up. So that puts us at 12 months post the initial imaging. If we are stable, at that point, again, remembering these lesions are allowed to grow a little bit. They're hormonally regulated, so a little bit of growth is still considered benign. We're just trying to look for that rapid growth that would either indicate a malignancy or a phylloides tumor. So if stable, we say BI-RADS 3 again, and we do a 12-month follow-up. Now, if anything changes, it increases in size or morphology in a way that we're not happy with, we determine it's a BI-RADS 4. And if it's stable at 2 years, we can call it benign. Or if something changes, so we've got a solid lesion, we're at the 12-month follow-up, the woman has her mammogram and ultrasound again, and our well-defined solid hypoechoic lesion now has popcorn-like calcification, which is a benign feature of involuting fibroadenoma. It is benign, and we can stop. We don't need to complete the 2-year follow-up of that lesion. Now, at any point, we will say this a few times tonight, if there's any discordance between clinical examination or there's some additional findings or concerns. So I know there are women who have a strong family history of breast cancer. They present with a very typical looking complicated cyst or fibrocystic change or a likely fibroadenoma. Don't make them anxious. If it's less anxiety producing to have a biopsy, I would recommend that you do the biopsy. So BI-RADS 4 is suspicious, and for argument's sake, we're divided into 3 categories. And with experience now, I will assign A, B, and C, but I'm not quite sure how I've determined something is 45% chance of malignant or 55% chance of malignant, other than to say, I'm pretty worried about this, or I'm less worried about this. And it's really just to say that features, they do not have the classic appearance of malignancy, but are sufficiently suspicious to justify the recommendation for biopsy. So BI-RADS 4 equals biopsy without question. And the caveat to this is going to be how we interpret the result. So a BI-RADS 4A lesion, if it comes back with an explanation and it's benign, I would accept that. So these would be things like PASH or stromal fibrosis, all of those things. They need a biopsy. They're suspicious enough, but we would accept a benign result. But once we get into that 4B, 4C, we are considering a surgical opinion or definitive management, obviously, if the biopsy result is malignant. But BI-RADS 4 equals tissue. So BI-RADS 5 is a bit of a classic descriptor, and that was before we really did a lot of neoadjuvant chemotherapy, to be fair, when this was first written. So historically, it was used when something was so suspicious on imaging that we wouldn't even try to biopsy it. We would say it is so definitively a malignant lesion, the patient should be managed definitively at the first instance, but this happens less now. So we will call BI-RADS 5. It's a big red flag. I would be inclined to say, as a GP, if I had a patient who had a BI-RADS 5 lesion, they are going to have that lesion excised regardless. As soon as a radiologist is making this sort of call, they need a surgeon. So it doesn't matter what the biopsy says. So if you have a patient who has a BI-RADS 5 lesion, their biopsy is booked for 3 days, 5 days, 7 days, it probably doesn't matter. Getting that referral into the surgeon as soon as possible, generally in my experience, by the time the patient has seen the surgeon, they're planning an operation regardless, and the biopsy is just part of the biopsy result is normally with the surgeon at the same time as the patient hits their clinic. So I think it's very reasonable in a BI-RADS 5 lesion to refer without a tissue diagnosis from the GP. And certainly I know in my networks, our surgeons in our hospitals will accept that as a Cat 1 referral. BI-RADS 6, increasingly used now. We have so many neoadjuvant treatment opportunities that we use it for biopsy-proven malignancy. So when we're following up, when we're for tumour response, if the patient has not had definitive surgical management, BI-RADS 6 is used. We don't use it for BI-RADS for lesions that require further examination. So you will see in a report that lesions get assigned a BI-RADS category, and then the study gets assigned a BI-RADS category, and which is the highest BI-RADS category. So you may have a BI-RADS 6 lesion in the right breast, however, they've now had their completion imaging of their contralateral breast, and there's a suspicious lesion that's been allocated as a BI-RADS 4, which says we need to biopsy that site as well. This has been borrowed from Cancer Australia. This is a table that is actually about, reflects the guidelines to the Breast Screen Australia services, but I think it's quite nice as a summary of when we should use FNA and when we should not. But essentially you can see, except for a simple cyst, we are really doing core biopsy for almost everything else. From our point of view, we always send for cytological analysis if we aspirate a lesion, and that is to satisfy Medicare most of the time. And because once you've taken it, the recommendation is that we confirm that it is a benign lesion. So everything else, we don't recommend FNA. Lymph nodes, there is mixed practice. I try to core biopsy as many lymph nodes as I can. I find I have fewer surgical upgrades at sentinel lymph node if I've cored the lymph node before operation. I won't spend too much time. You can come back to that if you need the details. So we go back to our chart here, and these are the 4 components that I think we need to be aware of and where there's some confusion. So a simple cyst if symptomatic. So to me, symptomatic is pain or increasing pain over serial cycles, not just a palpable cyst. So these women who have their cysts drained, sometimes they reaccumulate and we're just causing increased risk without any benefit. But if they've increased in size, if they become inflamed, then obviously that's an indication for more of a therapeutic aspiration, not a diagnostic one. As I said, it's a MBS billing requirement to send our fluid for cytology. And if we don't send fluid, we need to consider private billing. If you've done an FNA and it has come back as atypical or equivocal, I would recommend that you do a core biopsy before you refer to a surgeon. You will just help everyone's pathway in that case because that is what they will ask for. And the last component is this inadequate and insufficient. So repeat biopsy is an option, but I'd also say that ongoing review is an option. So if you see the report that it said the cyst is a typical looking cyst, it has drained to completion, the fluid was typical cyst fluid aspirated, and then you get an insufficient result, it actually means the fluid is acellular. The cytologist needs a number of cell clusters and epithelial cells to definitively call fluid cyst fluid. And if they don't have it, they call it acellular and therefore inadequate or insufficient to make a diagnosis. So just be cautious before We get too worried about these things. The alternate to that is that there's a small papillary lesion there, but often we're not missing the boat with malignancy. Malignant lesions like to give up their cells. This is a combination also from Cancer Australia and also this study around the safety and efficacy of VABs. VABs are a lovely test, and increasingly we are using them in our clinics, not just under mammography, but also under ultrasound. And you can see the sensitivity and specificity in this study was amazing. The upgrade rate at surgery is far lower than any other type of biopsy that we do. But it is more invasive. They are bigger cores. The complication rates are slightly higher because, we have vacuuming tissue into our aperture, and we can get vessels and cause bleeds in those circumstances, but we are watching under imaging. So we do know when that's happening, and we can act in the moment to minimize the complication. We do obviously, and we do have to allow for more time, and that's generally the setup. The actual biopsy component is very fast, but it has very good predictors when it comes to grading tumours and looking at receptors. Again, if at any time there's clinical and radiological discordance, just do the biopsy and consider surgical referral. And if there's a radiological pathological discordance, so the radiologist has called a BI-RADS 4 or 5 and you get a benign or normal result, consider repeating the biopsy and surgical referral. Now, I am aware that we are getting along in time, so let's go through risk assessment, the who and when and how of moderate to high risk screening, because this often falls to the GP to be the net that catches these high risk and moderate risk women. And certainly that moderate risk is a very challenging place for all of us at the moment with what we're recommending, because there are a number of guidelines and they're not all saying the same thing. So we can look at the European guidelines and the American guidelines and our guidelines, and we're sort of trying to work our way through. So firstly, with risk calculators. So I basically only use 2 risk calculators, and the first, as accepted as a clinical resource by your college and by mine, is iPrevent, noting that it's not suitable for women who have had breast cancer, obviously men, too young or too old, previous mastectomy, known gene carriers, other blood relatives with abnormalities. It doesn't account for these women who have had radiation therapy, and risk assessing half relatives, so steps and half sisters and all of these. I'm sorry, half sisters, not stepsisters, with the more complicated background of cancer history. So I tend to use, we'll go into when I use them. So iPrevent is the first option, and then the trickier, longer risk calculator is IBIS, or the Tyrer-Cuzick model. So there are a number of online platforms that patients can access. It's trickier as clinicians. They block our IP addresses if we use them in clinic. So we can purchase these for clinical use in high-risk clinics. And it's the assessment choice with women who have a family history of breast cancer in first or second degree relatives, increased breast density, and any kind of weird and complicated background. So I'm going to start our moderate to high risk screening chat by saying every Australian woman is eligible to have breast screen as long as they are asymptomatic over 40 years of age. So firstly, everyone is eligible for this. What we're talking about is how do we maybe supplement breast screen or give the best information to our patients about when screening with breast screen is the best test and when extra studies are required. So population risk is how we're going to start. So population, moderate and high risk are our 3 groups. So general population lifetime risk is about 11%, but for the arguments of categorizing people, we accept that lifetime risk is up to 16%. In A and B density breasts, these are my recommendations. I have not published a guideline, but I think in these women, population risk, low density breast, mammographic screening with breast screen is a perfect test. I am a personal advocate for screening from 40, so I do recommend to women that they reach out to breast screen and start screening from 40. However, as you know, they'll be targeted from the age of 50 to 74. If a woman decided they did not want to go to breast screen and they presented to a private clinic, most commonly they would have tomosynthesis as their standard test rather than 2D mammography, and would be a recommended 2-year rescreen. In women who are a C or D breast density but population risk, the recommendation now is to have a supplementary modality. So women will have a 2-yearly 2D mammogram, and currently, ultrasound screening is not available through breast screen. So these women would require a private referral if they wanted to supplement their screening mammogram. Privately, the most common in this group would be women having a 2-yearly tomosynthesis and ultrasound. And now where we are at the moment is considering, are these women better treated with a 2-yearly SEM, given that we know the cancer detection rate in contrast mammo in these dense breasts. That's where the benefit of this study is. And if we do contrast enhanced mammography, a negative contrast mammogram is extremely sensitive. And the studies are coming out now that adding ultrasound as a screening test in these women, if they've had a negative SEM, only adds confusing features and they only find benign lesions. So adding ultrasound is not improving our cancer detection rates. So therefore, ultrasound could be reserved in these women who have a negative SEM if they've got a clinical finding that they want a targeted ultrasound for, or if there was something on their mammogram to target. Moderate risk, 17 to 30%, and these women have a 3 to 8% chance of developing breast cancer between the ages of 40 and 50, and therefore I would recommend starting screening at 40 in these women. Again, the default would be 2-yearly unless they have a specific indication for screening within the screening program, which is previous cancer, a previous high-grade, high-risk pathology on biopsy, one first-degree relative diagnosed with breast cancer before the age of 50, or any specialist recommendation. So if a woman has gone through a process, they've gone to an MDT, they've seen a surgeon, whatever that might be, and they have said, we recommend annual screening, the breast screen services will put them on annual screening. So privately, we would probably give these women annual tomosynthesis with an ultrasound. Again, we're in the same circumstance. Do they have SEM plus or minus ultrasound? And some women in this group do choose, particularly the women who are moderate risk and high density, to privately fund an MRI if they don't have access to contrast enhanced mammography. Important to note here, thyrocusic can be repeated every 5 years until the age of, well, it can be repeated every 5 years, as increasing age will increase their 10-year risk. I say until the age of 60 because that's when the Medicare MRI rebate ends at 60. So talking about MRI, this is the high-risk screening MRI MBS criteria. So as I said, younger than 60, so they need to either have a high-risk cancer gene mutation, which is pretty self-explanatory. There's this indication where you have a first or second degree relative with breast cancer under 40 plus another one with bone or soft tissue sarcoma, a personal history of breast cancer before the age of 50, so they can, a woman with young, diagnosed with breast cancer at a young age can have screening MRI until she's 60, personal history of mantle cell radiation. But this is the important part. The greater than 30% lifetime risk or greater than 5% 10-year absolute risk using thyrocusic as a good test is eligible for high-risk screening. So I have compiled this very complicated stepwise approach, and this is what this is my opinion joining these two things together and what I would like to get across to you this evening. So a woman comes in and has a very high level assessment with her general practitioner for her personal and family cancer history. So if there's no history whatsoever, I tend to tell women and they're worried because their neighbour had cancer last week or whatever that might be. I reassure them and say, use iPrevent, reassure yourself that you're a population risk. Now, in women who have a distant family history, you're not quite sure, Depending on the level of complexity, I would say iPrevent or Tyrocusic. So if they tell me that their great aunt had breast cancer, I probably would put them towards iPrevent. But if we're talking about cousins and half siblings and, one step away but still fairly close, then Tyrocusic is where I would recommend they go. And obviously the women who are like, I've got a cousin plus an auntie plus a half sister and my paternal grandmother and this very complicated story, then definitely Tyrocusic is the right test for them. Now, from those two risk assessments, you'll end up in a population moderate or high risk category. If iPrevent says they're high risk, then I would go and do Tyrocusic to get a better idea of what that risk truly is. High risk are straightforward, refer to a breast surgeon or a high risk clinic. They'll be screened with MRI. They'll also get screened with some mammographic study to look for the calcification, as I said. Women who are moderate risk are the hard ones, as I said. So I would say contrast mammo is lovely, plus or minus ultrasound. If you're having tomosynthesis, I think you need ultrasound. And then population risk, breast screen mammography. The caveat to that is the women who are high density. So I think the women who have high density in their breast screen mammogram should have an ultrasound. And I think women who have moderate to marked background parenchymal enhancement on their contrast mammo or their MRI should also have an ultrasound to complement the studies. And that brings me to the end, and I've not gone too far over time.
Thank you very much. No, you went perfectly to time. We've got some really good questions this evening, so I'll try and get through as many as I can. So the first question, this is a really good question. I know it's a common question. Breast surgeons often say they want to examine the patient and the lump before we perform a biopsy. And we're just wondering what your thoughts were on this.
I think that is true if it's a biopsy for a palpable lesion and we can't find anything. It wouldn't be my experience. If you had a suspicious lesion, I think most surgeons would be happy for you to proceed straight to biopsy to further the patient along in that pathway. I understand if we thought it was benign or the initial imaging said no abnormality, I do, before we biopsy strange things, maybe some surgeons would agree, but I think if there is a lesion, the definitive answer really is going to be the pathology.
Great, thank you. And if you may have touched on this, but if we can just remind the audience, so if we perform a contrast enhanced mammogram, do we
Yeah.
still need to do an ultrasound at the same time?
So the studies that have come out, as I said, basically a negative contrast mammo or, a very minimal background parenchymal enhancement, mild to minimal, definitely nothing suspicious and no clinical findings is an incredibly powerful rule out test. And as radiologists are getting more used to SEM, and there is a learning curve for us as well. So most of us as we have implemented contrast mammo, we have been continuing with the ultrasound just for our own reassurance, and that's the safe way to progress. But certainly the data is now saying that we can move to no ultrasound unless there is a mammographic abnormality that's new, and therefore we're actually using the contrast mammo. We're using the ultrasound to assess for lymphadenopathy. And we're assessing for an ultrasound guided target for biopsy because, as we said, ultrasound is a much preferred biopsy technique. So that's where that's why ultrasound is performed in those circumstances. But increasingly now in women who are coming for their contrast mammo and they've got no background parenchymal enhancement, my recommendation and that of many of my colleagues is next screening or next examination round, let's start with the contrast mammo only and add an ultrasound if we need to.
Great, thank you. Our next question, can you just touch on the process for investigation of a new breast lump in breastfeeding women, particularly preparation prior to imaging, so
Mm.
pumping, things like that?
Yeah, so it is very difficult, and we all know that. Um, and we know that so many like not so many, but we know that breast cancers can hide behind mastitis. So what we do is we try to get the baby into the clinic with us, and so let the woman feed immediately before her mammogram, because that's actually the difference. Um, so we feed if we really think we need the mammogram. Generally speaking, we'll start with an ultrasound. If it looks like mastitis, if it looks like an abscess, we'll manage it accordingly at the first interval and then repeat the imaging at a short interval to make sure everything goes as planned. Um, so ultrasound first, feed the baby, do the mammogram if we need to. We're really only going to mammogram if we think there's something suspicious and we're looking for that suspicious type calcification. Contrast mammo, I think most of us have now determined is completely useless in a breastfeeding breast. It's safe. The contrast is not the issue, but the amount of background parenchymal enhancement makes the study very difficult. And we don't lead with mammogram because of the increased breast density, so increased dose. It's sensitive tissue when we're lactating. So definitely ultrasound first. Then we would go to mammogram if we had something very suspicious, and we would consider an MRI.
Great. And can you just touch on how you would manage women presenting with breast implants?
I guess the question is what the question is. So women with breast implants should still have mammography when it comes to workup. There are a few different ways depending on if the patient has pre-pectoral or post-pectoral implants. So women who have subpectoral implants do have an easier time with their mammogram because we've got a tissue plane between the breast tissue and the pec, and then we can displace the implant more easily. But we can always add extra views. We can reduce our compression. So when it comes to mammography, generally speaking, very safe. And we modify depending on our technique. So that, well, I shouldn't say we, but our mammographers are very good at that. And then we do an ultrasound as a second test. When it comes to implant integrity, the gold standard is MRI. However, it's a reasonable screening test to do an ultrasound. We can look for peri-implant fluid if we were looking for implant-associated lymphomas. It's a nice first-line test there as well. So I think the take-home really is try mammography. Some form of mammogram is important, even if it takes us soft compression and 3 views to assess their breast tissue.
Great, thank you. And we have a question about CT cone beam. Just
Yes.
wondering, is CT cone beam better than MRI?
Or it's not better than MRI. It has a place. So the benefit of CT cone beam is the benefit of CT, which is you end up with a volumetric data set. So as I said, with the tomosynthesis, while we are imaging in 3D, we can't move the data around to make an axial or have a 3D view. And I know the surgeons really like that. And I know women with breast implants really like the lack of compression, but it's not, at the moment, MRI is still considered the gold standard, and it has its place. And so the current push forward from a contrast point of view in women who have increased breast density, I think will continue to be contrast enhanced mammography for its broader applicability.
Great, thank you. And we are perfectly on time to finish the evening at 8:30. We had lots of questions this evening. We didn't get through them all, but we'll endeavour to get those answered and we'll put those up on our website. If you can stay online at the end of the webinar and answer the evaluation survey in the handouts tab. These evaluation surveys are really important. They help us keep the education relevant for GPs. And I'd really like to thank Dr. Katrina Dahl for her presentation this evening. It was extremely insightful, and we thank you for your expertise. And thank you to our audience for joining. Have a great evening.
Good night.